Let's get started. So my name is Gale Burstein. I'm the Erie County Department of Health Commissioner and a pediatrician, and also I've been prescribing buprenorphine for adolescents and young adults. And I just want to welcome everybody. I really appreciate people being here in person, and I also really appreciate people tuning in virtually if you couldn't be here in person. So really want to share some great information. So I'm here to welcome you to our task force meeting. Let's see. Just want to, right. So, is that it? Sorry, of course, thank you, some technical difficulties. So I just want to welcome everybody for joining us. And just want to let you know that we have a great agenda that Taylor's going to go over. And initially, I want to just introduce Taylor Winter, who is our acting director of our overdose, our Office of Harm Reduction and our Overdose Prevention Task Force. However, as you go through and as you go through the meeting today and listen to all the good things that are happening with the task force and our Office of Harm Reduction, I just want you to keep in the back of your mind that we're looking for a new, hopefully more permanent Office of Harm Reduction Director. So if you have an interest or if you know somebody who would be a great fit, we're gonna show on the presentation how you can submit your application, or that people can submit their application for this position. It's really easy to apply. I think, of course, the difficulty is actually starting the job. But it's a great position. You see that there's a lot of potential, and there are a lot of great things that we're doing now, and we want to restructure so we can do some more. So I'm going to turn it over to Taylor.
Thanks, Dr. Burstein. As Dr. Burstein mentioned, we are accepting applications through November 15th. The application or how to apply is not in this presentation, but I will actually send them out after we are here today with all the question and answers with the link. And so really easy, create your resume, update that, send that to Tia Johnson, and her email will be in the posting, and then we will be in touch with some next steps. And if you've already applied, we appreciate. We are waiting to review all the applications until the posting closes. Here's the agenda. We are going through our welcome right now. Dr. Burstein is going to talk about our local data. This is our epidemiology section. So we're going to learn about some pleasant numbers, which is really exciting. She's going to share more on that. We're going to talk about some new maps that our data analyst has put together as well. Jump into our work group report out. So as normal, all of our work groups are going to come out and talk about what they've done and accomplished and will be accomplishing over the next couple of months. And then we have a new section. This is really a specialty area. So I'm in this area when I look at opioid settlement monies and be able to give you a little bit of an update. But I would like to, as we move forward and we get a new director, I'd like to keep this section for some guest speakers. And so I know New York Matters has some really exciting improvements and changes. And so we're hoping to get them to be a guest speaker for the next task force meeting. And if you think your agency has something large enough to share that you'd like to be on our agenda, reach out to us. Let's get you on the agenda. But we also will have a community share out section. And so this is going to be if you have an event, if you have a new program, and you just want to quickly give a blurb out to the community, that's where you can do that there. We will be taking question and answers at the end. If you think you might forget your questions, please write them down. Virtually, Melissa will collect all the questions and she'll report out at the end. We may have answers, we may not have answers, but regardless, we will be able to send out all question and answers to the entire task force with the agenda and the recording at the end of the meeting. And then closing, we also, the new addition is we do have a feedback survey that we would love to get your feedback for. Couple of housekeeping things. I'm going to turn it over to Ken to talk a little bit about some emergency strategies or preparedness.
Good morning, everybody. Just real quick. My name's Ken Peterson. I'm the ALS Systems Coordinator for Erie County. My office resides in this building. So those of you who have not been here before, just to kind of give you a heads up, if you exit out either of these doors into the common area, straight down the hallway through the double doors, men's room to the right, female's room is just on the other side. In the event of an emergency, obviously, there's a fire department here and so on and so forth, but if the fire alarm does go off, we will evacuate the building out either of these doors down the hallway, and we'll congregate in the main parking lot area. Get a head count at that point, and then once everything's all deemed as safe, we'll bring you back in here. But if you have any further questions about the facility or anything, don't hesitate to ask. Thank you.
Fire training has also invested in some great technology since our last meeting. So I believe that we are one of the first public meetings that are happening using the technology. So you virtual participants, there's a chance that we might be coming on very strong. I do talk very loud, but with the sound technology, we might be coming on a little bit louder. So just let us know, and Melissa will flag us if we should quiet down a little bit. And hopefully you can also see us on our camera that is surfacing the entire front of the room and not just off the laptop camera. So that is another improvement. So we're excited to trial this. The other change is we have a moderator to our virtual participants. Please feel free to interact with her, with Melissa. Melissa Kennedy is on our virtual team. She will be making sure that audio and visuals work, as well as collecting all question, answers, comments. And the last thing, instead of signing in physically and on a form, we have changed to a electronic sign-in capture form. So I would love if you could take a second, in person and for virtual participants, including Erie County staff, if you could sign in using this form. I will also send this out once we are done. So in case you were unable to capture this or come in the middle of the meeting, you have a chance to sign in. If for some reason your technology is not working or our technology is not working, I do have a physical sign-in form, and you can do that when you leave. Good morning. I'll give everybody just a couple more seconds to snap a picture of the QR form or code. Wonderful. Okay, I'm going to turn it back over to Dr. Burstein, and she will talk more about our data numbers. Dr. Burstein, do you want the? Yes, it should work.
Great. So again, I'm going to talk about our overdose data, both fatal and non-fatal. And really, for the first time in, I think since 2019, I finally have some good news to share. So we're finally, with our overdose deaths, we're finally starting to see a slowdown. So for the first time. So again, you've seen this graph numerous times. This is looking at the number of overdose-related deaths in Erie County from 2012 to so far what we have confirmed and suspected in 2024. The blue line corresponds to the opioid fatal overdoses, and the red line corresponds to all the fatal overdoses. So you can see, if you remember, we had previously, before the pandemic, we had a peak in 2016. We formed this task force. We all started working together as a community. We were able to bring those numbers down through 2019. Then the pandemic hit. Everything changed. People were alone. Fentanyl started infiltrating the cocaine supply, and we started seeing more deaths in every year until this year, 2024. Our medical, so there are still, of course, many deaths that are still suspected and not confirmed. However, I think you can tell by this graph, this is through the end of October. So there are only November and December left. So it's very unlikely that we're going to have higher numbers than we did in 2023. So, and also anecdotally, our medical examiner's office has told me that they're definitely seeing a slowdown of cases coming in to their office with suspected drug overdose. So I think, overall, it's a good news. I know that I'm going to show you some data that nationally and statewide, there's a trend for also decreasing fatal overdose numbers. And so finally, we're following that trend. And I think collectively, the good work that we've all been doing, the changes that we've made into our strategy, the all hands on deck approach that we've taken has really paid off. We're really finally starting to see a slowdown. Still have too many. These numbers are too high. However, I think we're going in the right direction, and hopefully, in the spring where everything is confirmed, I can provide some data that show that we've reached that final direction that we wanted to see. So this is looking at the demographics of both the Erie County population, which is in the first column, according to the 2020 census, and then the demographics of our overdose death victims from 2018 all the way to the confirmed cases in 2024 on the right. So you can see that, since we started on this journey, we've had a change in demographics, and we're really seeing some significant disparities here. So just, since you've seen this before, I'm just going to quickly go through it. Just want to point out that people who are categorized as white by the Erie County Census are there's about 80% of that population, whereas 60% of our overdose death victims are categorized as white. However, for Black individuals who are categorized as Black according to the 2020 census correspond to 14% of our population, but they make up 33% of our overdose death victims. So again, there's a really big disparity there, and that's something that we have to remember when we're targeting our interventions. Age-wise, we've also seen an increased age of our overdose death victims. So, remember at the beginning of this journey, we saw the disparity where there was a much higher proportion of our overdose death victims who are young people in their late teens, 20s, and 30s compared to the census. Now we're seeing higher numbers of overdose death victims who are in their 30s, 40s, 50s, 60s, and beyond. So just want to point out people in their 30s in Erie County make up 13% of our population, but they make up 22% of our overdose death victims. And again, in 2018, our people who are 60 and up, although they make up 25% of our population, in 2018, they made up only 11% of our overdose death victims, and now that's more than doubled. They make up 24% of our overdose death victims. So again, those are things that we have to keep in mind with these disparities when we're thinking about who we're going to target, what our messages are, and looking at what our peers should be doing and where they should be going. And I'll show you, we've been mapping some of our data, and I just want to give a thank you to Jason, who's done a really good job mapping. So this is looking at our percent of our overdose deaths by the type of substances detected from 2020 all the way to on the right, all the way to 2024 on the left, all the way to 2024 on the right. So you can see that fentanyl and both fentanyl and cocaine correspond to the purple. Cocaine only with no fentanyl corresponds to the dark green. Fentanyl with no cocaine corresponds to the dark purple, and everything else other corresponds to the light green. So again, just want to remind people, these are all polysubstance overdoses, but I'm just showing you data with fentanyl, and cocaine, just because of those are the most predominant drugs that we're seeing in the fatal overdose tox screens. So you can see that starting from on the left, we're looking at data from 2020 to 2022. We've seen a significant increase of both fentanyl and cocaine, both individually and combined. So it's really fentanyl and cocaine which are killing people, which are seen in the tox screens of our overdose death victims, either combined or separately. And with, again, talking to our medical examiners, it's always richer to get more of a history of people who are on the scene. So they report back that they're seeing a lot of white powder. So we're still seeing deaths from people who are injecting. However, we're seeing a lot more deaths of people who are smoking or snorting. And fortunately, we're not seeing as many injections and needles because those cause other health problems. However, we're still seeing too many overdose deaths. So, and again, this is a slide looking at the percent of all our opioid-related overdose deaths that have both fentanyl and cocaine from 2016 to 2024. So you can see again, about 2/3 of our opioid overdose deaths have both fentanyl and cocaine in their tox screens. So again, this is a very deadly combination. And now we're looking at where our overdose death victims live and where the overdoses are occurring. So this slide on the left, there's a graph, and it's looking at the percent of fatal overdoses that occurred in Buffalo among people who resided in Buffalo. So you can see that about 90% of our overdose death victims have who died in Buffalo lived in the city of Buffalo. So again, we're seeing more of a problem in the city of Buffalo. Again, we're seeing a problem all over the county. We're seeing a trend toward increasing numbers within the city of Buffalo. And remember, the residents of the city of Buffalo only make up about 30% of our total Erie County population. So again, there are disparities there. And then on the bar graph on the right is looking at the where people have died from an opioid overdose. So on the in the blue is looking at the proportion of people who died in the city of Buffalo, and on the orange is the proportion of people who died outside the city of Buffalo. And you can see that there's a trend that even though much more people live outside of the city of Buffalo, there's more people dying within the city of Buffalo. And then again, this graph on the left shows us that many of them are residents. So again, that's something that we need to think about when we're focusing resources. Again, we still have problems in our suburbs, Cheektowaga, Amherst, Orchard Park, and even in our rural areas. However, looking for where we're seeing the greatest number of overdoses, we're seeing them both fatal and I'll show you non-fatal within the city of Buffalo. So, in the big picture, we're finding that when we map this out, that about 2/3, most people who died of a drug overdose have died at their home, the address that's listed in their home. And then another 10% died very close to their home, just within the same zip code. And these have been persistent trends for the past couple of years. So again, that's something that we need to keep in mind. So going back to looking at national and state data. So these are data at CDC looking at the number and the changes of drug overdose deaths in New York State. You can look at it all the United States, and here I'm focusing on New York State. So you can see the good news is that compared to 1 year ago, New York State has seen a 17% decrease in drug overdose deaths. And in the United States, that's also a trend, not as strong. In the United States overall, we've seen a 13% decrease in drug overdose deaths compared to a year ago. However, those are all good trends. We're moving in the right direction. We're doing, at least we're doing something right to bring down these numbers. So that's all good news. And I have the link to the data down here. The CDC updates the data every month. So now I'm going to move on and talking about our non-fatal overdoses. So this is a slide looking at the number of non-fatal overdoses from January 2023 up through October 2024 by month. So you can see that there's been a trend, especially in September, there was quite a spike of non-fatal overdoses. And one of the hypotheses is that, we don't know for sure, but one of the hypotheses that at least as we think is contributing to the decrease in numbers of fatal overdoses is that we're doing a great job of harm reduction, getting Narcan out there, getting test strips out there, making sure that, people are engaging in solid harm reduction. So even though they are overdosing, they're surviving and living another day. So hopefully there's time to, to make those changes to get people into care and treatment. But there's been some publications in the literature lately that shows that, looking, overall at communities, there's been a substantial increase of lay person administration of naloxone. So again, we believe that it's probably likely here. We don't have, a good way to, systems to capture that. But in areas where they do have a good way to capture that, they're seeing that even though the EMS number, the number of Narcan doses administered by EMS haven't changed, the number of naloxone doses admitted by lay people who just happen to be on the scene or, in the room where overdose happens have really significantly increased. So, that tells us that this is working. And so we still have to continue being aggressive with harm reduction, getting the Narcan out there, making sure that people have access to test strips. So at least they can be a little bit cautious when, if they find out that there's, fentanyl in their supply, what they thought was cocaine. And then Jason Muirland has done a great job mapping out our overdoses, both non-fatal on the left and fatal on the right. So this is looking at where our non-fatal overdose data comes from we get that pretty much each week from PIDA, who obtains their data from police reports that are submitted electronically when they go to a scene, and they have to complete their reports, hopefully before they leave. And so those are the data that we use for our non-fatal overdoses, whereas our fatal overdose data, that is derived from our medical examiner's office. So there are different sources, so just keep that in mind. But however, we're looking at we're trying to look at those same data so we have consistent so we'll have trends to look at consistently. So on the left, looking at our non-fatal overdoses, so the darker numbers, of course, the darker shaded areas correspond to the higher numbers. So the absolute numbers I don't think are important. So because again, we have to appreciate that there are a lot of overdoses that law enforcement is never going to respond to. They're not getting called. So again, we're just looking at trends. And so you can see that we're seeing a lot on the west side, they're in the Grand Ferry area, and then we're also seeing a lot on the east side and in South Buffalo. Looking on the right of our fatal overdoses, we're seeing a lot of fatal overdoses on the east side. The 14215 zip code is really lighting up. Also seeing some kind of in the northwest part of the city of Buffalo, and also in South Buffalo. So again, those are available on our website, and if you're again, these are really important data just to figure out the certain limit of the pie. So where are we going to focus our resources? So these are both important, and we have to make sure that hopefully some putting more resources in harm reduction on the east side would looks like it could be a good investment. So should I go on to the work groups? Yeah. All right. So I'm on a roll. So I'm going to introduce, bring up my chair, and I'm going to talk about our healthcare provider work groups. Now I'm going to switch out a little bit and talk about the. So since I have the bully pulpit, we wanted to go first.
Good to see you. My name's Chuck Block. I'm a physician at the health system. I was asked by Gale, it's been a while, like 6 months or more ago, to kind of come on board and help her co-chair the healthcare provider work group. And I'm an internist that specializes in hospital medicine. So.
Right, so it's great because we have, somebody, on the hospital side involved with one of our major healthcare systems that is a co-chair of the work group, so we can look at different aspects, hospital-based, and then clinical community-based, and trying to target all of those. So I'm going to turn it over to Jeff just to talk about hospital-based systems either. So.
Well, better than what I'm used to. So really, what we're really focused on is to really look at healthcare systems, kind of looking at making things more routine and identifying patients who use substances and provide treatment. Interesting, the Catholic Health System kind of was on the bandwagon even before I started talking with Gale with this kind of, finding patients, because our screening methods were pretty archaic. And also kind of dispensing harm reduction tools in physician offices. And again, Gale and other providers in Buffalo are really spearheading this. So really my focus really is more in the hospital-based, although, I do, add some value to, outpatient things too. But so the Catholic Health System, even before we started talking, Gale and I, really, was a need, and it was identified by physicians, the leaders at Catholic Health System, that our screening really was archaic. Pretty much it was, do you use street drugs? And it was, routinely collected by the triage nurse in the emergency room. So we kind of expanded it into both triage nurse in the emergency room and the admitting nurse in the hospital. And it actually is a more detailed subjective history of, do you use drugs? How much? What do you use? I know to me, this is a win because it's much more collective and much more detail-oriented than just do you use street drugs. So if it is triggered, if they answer yes and whatever substances, it alerts the provider, either the physician extender, who could be a nurse practitioner or a PA, or the admitting physician itself. It also alerts the case management team, our case management nurse and social worker. The provider could then, take action, dive into the history more, order SEWA screens and COW screens if it's an opioid or alcohol use disorder patient, if appropriate. And our social worker and case management nurse are planning early for community resources or inpatient rehab. Because it's hard to get people linked, the day of discharge, you're running around to find somebody who can help them with methadone or Suboxone. And we've done that, we've been there. So it really kind of moves the discharge planning for people with substance use disorders, which is even more cumbersome than a regular discharge, to the forefront instead of to the high end of the discharge planning process. So, interesting, as a hospitalist doctor, I really work a lot with patients who come in pretty much are pretty sick. It's, bloodstream infections from injecting drugs. I mean, typically the overdoses, the non-fatal overdoses that I get, they're in the ER, they metabolize, they leave AMA even before we go down and see them. So the patients that we really get are patients who are in our hospital for a couple of weeks with bloodstream infections and endocarditis, multiple, medical issues. And we've noticed that, we really don't address the patient's substance use disorder while they're in the hospital. So we decided to look to do a research project to see how many patients left against medical advice, and could we impact or decrease the AMA or against medical advice discharges by providing opioid agonist therapy. Right now, we're in the process of data collection. We're tweaking this project a little bit with the help of people from the UV Research Institute of Addiction. So more to come on that. We have these two multidisciplinary groups, work in our community. We have the high utilization group, and this really looks at patients who they're in our ERs pretty much every week. And a lot of these patients have substance use disorders, as well as other issues, psychiatric issues. And we're providing care in the ER and then sending them back out in the community. It's a revolving door. Really, we had this high utilization work group, or we dived into this work group because we felt that the community itself could provide better care than we could in the emergency room. So we meet monthly, and our goal is to shift the care from just bandages in the ED to the community. So we're engaging primary care physicians who care for these patients, community resources, social work in the community, linking them with agencies, outpatient agencies, coming up with a care plan for the emergency room provider, the PA or physician or nurses who care for them in the ER, to kind of set the ball rolling, to not admit them in the hospital, to call their primary care or call certain individuals out in the community so you can move that person from the ER to get care out in the community. So that's one work group, and we meet monthly and discuss these patients. We currently have care plans for, I think, 118 high utilization patients, and a lot of them have substance use disorder. Another work group that we have, which really focuses on patients with complex care plans, which again, a high percentage of our people with substance use disorders, alcoholism, psychiatric disorders. And these typically are patients who are in the hospital, like they're currently bedded in the hospital. We meet weekly, kind of the same people that make up the first group make up, or similar people make up the complex care group. And we kind of look at a way, you're looking at the barriers to getting the patients out of the hospital, but it's not like getting them out of the hospital, but it's also setting them up for success once they're out. So these two work groups are really starting to revolutionize the way we treat a lot of patients with substance use disorders. So, and that's it. Any questions on that? And that's
Okay,
what
we'll do
you want to
questions at the end. Yeah. Thank you. And I just want to give kudos to Catholic Health. You know, there's always like kind of this big divide many times between the Kaleida UB side of healthcare and the Catholic Health side of healthcare. But on this, I mean, I think we're able to come together and systems are able to work together. We saw as an example of the research project that we're working. Catholic Health is working with UB, their Addictions Medicine Institute, and really Primary Care Institute, and looking at how they can improve what they're doing. So it's really a great effort. And then also you have addictions medicine consultation at Sisters Hospital, which is another asset. So I'm just going to run through a couple things that I'm doing with our community physicians. I'm mostly in the planning phase right now. So what we're trying to do is an intervention called academic detailing. And academic detailing is actually modeled under pharmaceutical detailing. So back in the day, pharmaceutical reps used to come to physicians' offices as to market their pharmaceuticals or their devices, and they come in with tchotchkes and colorful flyers about their product, and always had food. And so the literature showed that it really did change prescribing practices of healthcare providers that receive this academic detailing visits. So public health said, we should do that. So public health has been doing this, we call it academic detailing instead of pharmaceutical detailing. And literature shows that it has been successful when looking at changing prescribing practices for reduce the amount of antibiotics prescribed. And so we use this thing in other settings. So we're going to do, we're developing an intervention for public health academic detailing around harm reduction. So bringing the concepts of harm reduction into healthcare providers' offices. We know that many people who have a substance use disorder go to their healthcare provider. We know that's actually people with substance use disorders are visit their healthcare provider more frequently compared to people without substance use disorders, according to the medical literature. So we want to make it easier for healthcare providers to identify those patients that are struggling with these health problems, and also get them into the appropriate care. So we're putting together resources for to provide expert, or to ask maybe some brief questions to that are non-judgmental, that can identify patients. Also, helping officers understand that words matter and not using any type of language that is stigmatizing, making everybody feel welcome. Helping primary care providers with routinizing prescribing naloxone for their patients, or seeking pain medications, or maybe have somebody in their life that they may need naloxone for. Understanding about NCAPS, the New York State's naloxone program, where they cover co-payments, the naloxone access co-payment program, so that people who are have insurance, they don't have to pay any out-of-pocket costs when they fill their prescriptions for naloxone. So we're putting together these toolkits, and also I think the biggest barrier for healthcare providers just to identify patients with substance use disorder is now what? What am I going to do with these patients? Where are I going to refer them? Because they have no idea what this world is. Because unfortunately, with our siloed healthcare system, substance use, mental health is very separate from medical health. And so what we've been bugging Matters Network, and they've been gracious enough to develop a system where, when you want to call a specialist office and say, dial 1 if you're a healthcare provider. So we have so Matters is putting a system in place where healthcare providers can just dial 1. Well, actually, go online to refer their patients. So in the big, so there can be different scenarios. There could be patients who where the healthcare provider feels comfortable prescribing buprenorphine until patient can get connected to a long-term substance use treatment providers. There can be scenarios where the provider feels uncomfortable with prescribing buprenorphine, and so they will want Matters to do it in addition to getting them into long-term care. And then there are patients that are already on buprenorphine, or they already, they don't need a new prescription. They just need to get connected into long-term care. So so there's a system in place where healthcare providers can just go onto the website, and depending on what level of care the patient needs, they can, enter that information in, and they'll either be contacted, immediately while they're in the office, or if they just need a long-term prescription, they'll put in the information, and Matters will contact them either right away or just within a few hours. So now there is going to be theoretically no barrier for healthcare providers doing the screening to identify patients, because now they'll feel comfortable that they will be able to get them into the appropriate care. So that barrier is disappearing. So we're going to help healthcare providers understand that. Also, we're working with D'Youville University School of Pharmacy to do some interventions. First of all, they're going to do a secret shopper intervention. So they're going to go into pharmacies and see what it's like to purchase a dose of Narcan. Is it behind the counter? Do they get looks like, what do you need that for? Are they offered to use NCAP to pay for all their co-payments or the costs involved, out-of-pocket costs involved with purchasing Narcan? So we're going to have spies figuring that out. They're also going to do just a survey just to try to get a better idea of what routine practices are in the pharmacists. What they report about offering harm reduction and including Narcan dispensing and education, and when patients fill prescriptions of narcotics, do they also have a conversation with those patients about also getting some Narcan, either the non-specific New York State Health Commissioner order or their physician's specific prescription. And then we're also going to make sure that all our pharmacies in the area understand and are able to use NCAP, that it's not that difficult for them, and also that they understand, just, to help them routinize, talking about naloxone or Narcan, every time a patient goes and gets a prescription filled for some type of a narcotic or pain medication. So that's what we're doing in our work group. So thank you.
Thanks, Dr. Burstein. And Dr. Burstein mentioned some of our pleasant numbers and trends, hopefully, is going to be a trend as we continue with our overdose deaths. But we are working on, if you didn't capture all of that, and we only have a limited amount of time, we are hoping to put out some language and additional resources around that, especially when we look at the CDC suspicion that our overdose death numbers are decreasing. So our treatment provider work group, Jen, are you here? Juliana is not here with us, but Jen is with us. And we are still figuring out the new technology. So our speakers, if you can step on this side of the podium, if you want to be on camera. If not, then stay off to the side.
Just be a disembodied voice going on. That's cool. Hi, everyone. I'm Jen Seib. I'm the Senior Vice President of Strategic Initiatives at Best Self and a co-chair of our newly named Treatment and Prevention Providers Work Group. I just want to kind of note that we were always the treatment work group, and now we've extended and offered for our SUD prevention providers in the area to join the group. So more to come on that. So just a little bit about our group. We do meet monthly, and it's really open to everyone. We kind of focus on treatment in our Western New York area when it comes to behavioral health care treatment. But we have members from our peer cohorts. We have people that are from, obviously the county. We have people from Oasis, treatment and prevention providers. So we really want to have like really robust conversations and understand what's going on in kind of the landscape of our area when it comes to treatment services that are available. So we meet obviously the fourth Monday of the month there from 10:30 to 12. It is a virtual meeting. So if anyone is interested in knowing more about our group or joining, you can certainly email myself or Juliana, which our contacts are on the beginning of the slide. So one of the things that I think is really important to kind of note as an overall task force, we noticed that there was quite a bit of overlap with some of our work groups. So I'm sure maybe some of the other work groups will speak to this as well. But, I noticed as a treatment provider, some of the things we were doing in treatment space, some of the harm reduction folks were doing as well. So we thought there's so much work to do, and we certainly don't need to be overlapping our work, right? So we kind of took a step back and said, let's meet as the co-chairs that come together and kind of decide who's doing what and what does that look like and how can we best serve the community. So what we're doing in the treatment provider group is saying, and obviously this task force has been renamed. It used to be the Opioid Overdose, but now we're talking about overdose. And so as treatment providers, we're like, what's going on and what is it that we need to focus on to help people who are actually at that point where they're seeking treatment? We know not everybody's there, and harm reduction is doing a great job. But what can we focus on? So one of the things that we know is stimulant use disorder is a pretty big concern. We know that cocaine use, methamphetamine use is increasing. That is resulting in overdoses and overdose deaths. But if somebody wants treatment for their stimulant use disorder or for a polysubstance use disorder, how are we as treatment providers doing the best that we can? So we're trying to look into, there's some evidence-based practices out there, but they're not widely used or widely, used, I should say, yeah. So we really want to take a look into that. Some of it's not supported by Medicaid dollars yet, so we're really trying to take a look at how can we bring some evidence-based practices that show some promising, outcomes, and then be able to bring them into our network. We want to increase care for people with SUD, not just OUD, so obviously, opioid use disorder continues to be a concern, but we want to be able to do great work for everyone. And then a big thing that comes up in our group a lot is when people have a crisis, a substance use crisis, or they just have decided, I want help right now, but they may not meet that threshold of needing medical care, meaning they're not going to go into a withdrawal that needs medical attention. There's not really a space for those folks. So, we have hotlines to get access to medication. There's detox services available, but those are reserved for people that need that medical intervention and observation. So it's been a really great discussion we've been having. A lot of our peers who joined the meeting talk about trying to support people in the community that say, I need help right now. And they may go to a detox center and then they're turned away. Not because people don't want to help, obviously, but because they don't meet that threshold for that need for that service. But that can be very discouraging for people. When you decide today is when I want that help, and then you ask for it and you don't get that, that's that's a really big missed opportunity, and that can really cause harm. So we're talking about how do we find that space where people can really like, I want help now, and they get it regardless of their substance use of choice, you know, regardless of where they're at from a medical standpoint. So it's been really great discussions. This is just a note for people to be aware of. And I know the material will go out, the slides go out afterwards, right? So yeah, so there's also attached will be more information about this law, but just so that people know, there's a law that changed that Medicaid will reimburse for people going to non-emergency settings. So like medical transportation, ambulances can take people to, you know, some of these things listed here. So CCDHCs, FQHCs, and then crisis stabilization centers. So there's going to be more options. So I think it's a, you know, pretty interesting thing that people can, you know, call and get that emergency service and not necessarily have to be taken to an emergency department. So there's more about that. I'm not an expert in it. So what I wanted to share, this is what I think is a really exciting opportunity. So at Best Self, we're going to be starting soon, called Best Response, which is an intensive crisis stabilization center. So just to give you a layout about what that means, it is a place that is for very urgent needs, but not necessarily emergency room needs. And this is from a psychiatric and substance use perspective. So it really helps people that maybe present at the ER and then are turned away because they don't meet that need, but they would definitely fit here. So this is 24/7. It's for all ages, and people can walk in. People can arrive via transport from, you know, emergency transport or police, and folks can stay. I think we were at 23 hours and 59 minutes. You cannot stay for 24 hours, so there's no overnight. But while you're there, you really get that crisis support. So MOUD will be available to people on site. Obviously all kinds of other medications. There's peer services, there's medical services. So all of these things are happening in one spot. So I know the slide is busy. I don't want to like read everything to you, but I hope that you kind of, and I'm happy to answer questions to the best of my ability. But yeah, so all of these things are available for people. It will be located at 430 Niagara Street in the city. So really excited. And I really see this as maybe one of those opportunities where those people that are like, I need help now, this is where they can walk in and actually get that help. And maybe linkage to ongoing help if that's what they're seeking. And also the Kevin Beckman and Brittany Derry are at their names are on the slides. They're the ones that are leading the starting of this program. So they are also available. You can reach out to them if you have questions. And we did have them come present at our work group, which was really nice. So here are some other resources as well that are available. We just like, these are again, our work group has a lot of folks from a lot of different places. So it's great to pull all these resources together and let people know. So we have a grief and loss forum that is running, the East Buffalo Counseling Center, which I know I see Ann, so she's here to answer questions if need be, because I don't put her on the spot. But Spectrum has this program, which again, it's a walk-in access to get support. And you can see here there's peer support, rapid access to clinical counseling. So this is a place again where it's kind of that quick, let's get in and not have to wait a long period of time. Support groups that are available in the community that are led here. Again, for your information, share it as you will. And for our access to medication, so I'm sure most people are aware of this. I have it every single time on this number, but this is a partnership between Best Self and Matters, where folks can call this number and then be seen via telehealth by a provider and be given access to medication for opioid use disorder, and then linkage for ongoing care after that. So this is I think a super valuable resource in our community. Again, someone seeking that more immediate access. Also, we have in Erie County, we have the addiction hotline that people can call and get more information. And that's it. So our next meeting is at that time. Again, our contact information is there. And thank you very much.
Thank you. I think I do want to commend, I think it's really the 3 work groups, but mostly all of the work groups, is that I think prior to COVID, and this was a little bit before my time, but prior to COVID, the work groups really worked across each other and shared resources and interventions and really talked about how they can build upon one another. And then I think just through the nature of what happened with COVID and a lot of systems were broken and we had to kind of get back into the community and just make it work. We kind of lost that. And now it seems like a lot of the work groups are getting back to that and working across work groups and really picking up, even if there's an intervention that's not with the work group specifically, but being able to take pieces and parts of that and really getting it into their work group and building upon that themselves. So great work, and I'm excited to see where that goes. Our next work group is our first responder work group. Val is not here today, but we do have Ken and Jen who are going to share a couple of pieces of information. Want to go first?
Sure.
All right. And this is the only slide I have, Ken, so I don't know.
Yep.
Or may not.
So from the first responder work group perspective, at least on my behalf and working closely with Jennifer on some stuff, we kicked off last month a seminar series here at the Academy that's basically targeting first responders, law enforcement, EMS, and fire. Those topics are varying, and I'm working closely with a number of partners in the room to bring those topics that are applicable to first responders to those seminar series. So in October, we had our first, which was attended by 13 providers, or I should say first responders. This coming Thursday, we have our second one. So we're hoping this grows. We're going to run these from October through April each and every year to bring in first responders and touch on different topics specific to an opioid overdose, those types of things, and amongst other topics to engage those first responders. So if you have something that you think would benefit, it gives you a platform to discuss actively with those providers in the community of both law enforcement, fire, and EMS. So.
Awesome. Thank you. So Gale's not here, but I did get the chance to meet with him last week. So I'm Jen Garrigan. I'm embedded in the Office of Harm Reduction, but my work largely has to do with first responders. I work on a grant that is targeted towards them. So I just wanted to share a couple of the things that we've been working on. We recently have been in the works with Buffalo Police to provide a training video, because one of the things we're finding with law enforcement is that time is a huge barrier. So we're making our Narcan trainings more accessible so that we'll be able to administer it in a video. Buffalo Police is doing one, we're doing one internally that we can also push out to other organizations. And with that, we're wrapping in those leave behind pouches that I've talked about a couple of times. So HIDA has a push through the opioid response system that they are trying to get leave behind pouches in the hands of more things. They didn't realize we were already kind of doing that here. So we're working hand in hand with HIDA to implement that. And also with Ken, we'll be meeting with the chiefs next week to discuss that. And with the chief of law enforcement chiefs coming up probably in early 2025. And largely with that, a big portion of it is a lot of our folks know how to use Narcan. Now we need to talk about the details of when, how, why, and what does that correlate to with what substances we're seeing. Because some of the contaminants that we're seeing create a lot of different scenarios that our first responders encounter. So we're just trying to make sure that that education piece is as up to date as possible.
Thank you. And one thing that Jen didn't mention is that she has received a supplemental grant, really working on the TOT for a lot of, not only our first responders, but also our community. And I'm hoping, and if everybody is interested, we just revised our naloxone training and would like to look into providing a TOT training after our next task force. So if it's been some time that you have not gone through Erie County's training, updated data, updated discussions like Jen had just mentioned, we would love to hear your feedback if you would want to stay after the our work group meeting or our task force meeting and attend the TOT so you have that updated presentation and data for your community. And Jen, staying up here.
Well, I guess I'm staying up here. So I'm also the co-chair of the harm reduction work group. My co-chair Rebecca could not be here today, but I've got some updates for you based on the meeting that Jen Seib referenced, that we're kind of re-strategizing so that we can work together but not have so much overlap. So a couple of our goals and objectives. One of the primary goals that we have talked about historically is to have a map so that we can have people have more instantaneous access to naloxone. So we are working on that internally. We'll be mapping our open stands, those big purple boxes. We're also working to identify other organizations that may have that more 24/7 access and looking into different technology to see if we can add more to those maps so that we can have more information for folks that are looking for it in real time. We do have a wait list for our open stands. They are a very popular item, but please reach out to us if you are looking for one for your organization. So we're in the process of updating that. The other big thing that we want to do is to bring more folks with lived and living experience to the table. That is a huge point of effort for us. So with that being said, I represent the county. Not everybody's going to feel comfortable coming and talking to me and having conversations that they think may have me have some sort of judgment or expectation or consequence. So we are forming a subgroup that will be led by people with lived and living experience out in the community to do that work, because we want to be able to have that subgroup come back and give us the information. What are the concerns? What are the barriers that we're facing? What are the substances that people are looking for? What are they getting? Are they testing? There's a lot of different information that we can get wrapped into that by kind of taking a step back from the government piece and using our folks that are actually experiencing these things to inform our work better. So we are in progress with that. We are recruiting folks. If you know anybody that you think would be a good fit, please send them my way. So we are looking for somebody to head that subgroup up and for more members of it, as well as spaces that are comfortable in the community to hold those meetings. We want to make sure that we're bringing it to our folks, our people who actually need it. Something stuff. It did not transfer over. Okay.
Yeah.
Some of my stuff got a little cut off. That's okay. So another thing that we're working on is, let's see, we are forming another subgroup, which I bet is helping out with. One of the things that we know also is we need better surveillance of our drug supply here. We need to know what people are consuming, what contaminants there are. There's different levels of that. I know there is point of care testing that is in the works. IVET is going to help us run a subgroup around radar, which is surveillance monitoring that's de-identified. So it's not something that is shared. You can't bring somebody, you can't identify one specific person's substance. But what we can do is have a collective data of what folks are seeing. And it doesn't take much to do that. It's a wipe of a baggie, it's a wipe of a container, it's all these things, and we send it in, and then we can get reports back so that we can see what contaminants and what contents that we're seeing. So if you are interested in that, I know we have a couple of interested folks within the harm reduction work group that are working on that, but we will be meeting with New York State going forward to get that started officially, finally. So the other important thing that we've done is we've invested in a partnership with Endeavor Health to provide case management support for our peer navigators. So we have a part-time case manager through Endeavor that is helping those social connections, also helping with some of that medically assisted treatment, housing. They can help with
getting your license, all of these other things that may be a barrier for somebody who is seeking treatment or needing something. So we are trying to do that to help our peer navigators be able to serve this high volume of those non-fatal overdoses, because the fatals are going down, but more non-fatals means there's a lot more work to do. So we are trying to do that, and we also, they also have a 24/7 intake now, which is great because we were able to test that out in the field. We have some peers that have gone through with our case manager, Haley, to help out and see what that looks like, because not everybody is great with the whole virtual thing. Not everybody can do the telehealth. Some people need to be in person. So we have a lot more resources in Erie County than we used to for that 24/7 treatment. And that's another one of them. Also, one of our work group partners, Kate Van Rensler, who's here in the back. If you have anything you want to add, let me know. Or if you have questions, feel free to reach out to Kate. So we do also refer folks to that Best Self initiative, and they also have their low threshold buprenorphine clinic here. So there's a lot of really great resources that we have, and we're working on compiling them into one resource, so we're not fitting 16 different business cards into one thing. So it's a little bit easier to digest. We did have a bunch of staff also attend the harm reduction conference, the NYSHRA conference. Our staff, one of us staff was going to present on this. He's not able to be here today, but I do have some great notes that he took that I will attach so that we can send out as well. But we had 2 of our peer navigators were able to attend on scholarship, and we ended up having several other staff be able to go as well. So really it was about 2 days in Binghamton on a variety of topics. Biggest piece really being a lot of advocacy. There's a lot of space for a lot of us to do this advocacy work that we talk about. And then there was a lot of education on innovative services to address harm reduction through multiple needs. So one of the large presentations that a lot of our staff really reported back about was On Point, was the supervised consumption site, because it doesn't just provide, you know, the overdose response. There are wraparound services. You can get primary care. You can get healthcare needs met. You can help have that bridge to housing. You can have all of those wonderful things that folks are seeking out to support them in their life, to build the structure around them being able to live a healthier, happier life with less judgment. So there's a lot of different services there. And then again, that support for drug checking equipment. There was also, when we are talking about, Zach does a lot of work with our families. There's a lot of work that we can do as family members, as loved ones, to help support our folks. So they talked a little bit about the invitation to change model, which is largely empathy and compassion based. And it really shifts from a punishment mindset, like you have to do this, you're done, you know, to one of support. And again, instilling that self-worth in individuals can go a really, really long way. So above all, love, empathy, and support affect that positive change. So our next steps, really, please reach out to participate. I know we have restructured, so I believe I got everybody that signed up for the Community Harm Reduction Work Group. We are looking to bring our groups to the larger community. The training of trainers, we will be expanding that. As Taylor said, we did receive a grant, so we'll be doing larger symposiums as well with additional training and additional facilitators to help increase the knowledge and practice of harm reduction in our area. And we want to make sure that we're getting out into the community. So our large work group meeting is going to be hybrid, the 3rd Wednesday of each month at 2 o'clock for the large group, and the subgroups we are determining the best schedule for that right now. And then also after this, if you are somebody who works in the field, New York State has a login to learn de-escalation training that starts promptly at 12 that we will be holding for our staff in this room, and you are welcome to sit and stay between the hours of 12 and 1. Thank you.
Thanks, John. A lot of really great things. And for our last work group, Ken and Barb, they are coming to talk about our education, advocacy, and support work group. And feel free while they're making their way down here. I know not only did a lot of Erie County staff attend the harm reduction conference, but I know a lot of the professionals in this room also attended. So we will have a community share out portion. If there's anything that you wanted to share from attending that conference, please feel free to add on to all these conversations.
Hello, thank you. Hi, everybody. How are you? Had a funny little joke that I have to share. When Taylor called up Ken and Jen, he said, "Oh, that's cute, but it's still not Barbie and Ken." Still going with it. So we are the Education, Advocacy, and Support Group. Oh, these are small. Sorry, guys. So we are the new work group that basically brought together our old education and awareness group and the family groups together. I mentioned at our last meeting that we're working to get to know each other. That's a process that's still ongoing. Anytime you bring two different groups of people together. So we're getting everybody at the table and we're really working on getting to know each other and how do we really blend and meld our missions. We have, like a lot of the groups, resumed in-person meetings, also trying to offer that hybrid model so that as many people as possible can attend. So right now, what do we have going on? As I mentioned also last time, awareness versus outreach. We, want to continue with that. How do we make people aware of, like Dr. B said, it's good, some good news, that the numbers are decreasing. But then there's also that boots on the ground thing that we refer to as we really need to get out there. We did our tear off sheet. So please, public service announcement. I believe that it was shared with the entire group, our tear off sheet. Stop using it. And I will get it to Taylor this afternoon. We had a tweak to it that we need to, I will send her the updated ones. We have a full 8x11. We have a wonderful poster size one. And then we also have 3x5 cards that, for instance, Matt Smith, who's on our committee, has this wonderful setup at the Galleria Mall. I just saw it last week. If you want those little 3x5 cards, if you have display tables or anything, that's a wonderful use for something like that. So we will get you the updated one. Just we had to change a number on there. So we continue to work. It's a slow process on these PSAs that we have this wonderful vision for, just taking us a little bit longer because, of course, we all have so much going on. So, but we are working on that. As we continue to navigate our new work group and try to figure out exactly what do we look like, how do we go forward, one of the things though that we want to continue to do is support families. Was anybody at the events, any of the events on August 30th, the International Overdose Awareness? Those events were incredible, were they not? I mean, all of the events in the past were wonderful, but I don't know, this year was just, I wasn't at the ones during the day, but I was at the one in the evening. And I believe we have some photos, which
there's many photos.
Excellent. So I'll just kind of, for those who weren't able to attend, just give you a little, Dr. B was there. It really, such a beautiful day. It really is very touching. There's Zachary. I will tell you the one in the evening was scheduled, it was 4 to 6. There was tabling, a lot of fun things for the community. That was very well attended. And then 6 to 8 was presentations. Normally the presentations take maybe 45 minutes and, then people kind of mill around and then you're out of there. 6 to after 8 o'clock and not one person left. Not one person left. And the other beautiful thing about it was that it was on, it was at a school, community center school building, and it was on the street. And so people driving by or people who lived in the neighborhood, it was really such a public testimony to what was going on. It was so, as you can tell, I really have no words. It was just that amazing. This is the earlier event from 4 to 6. Our friends at Prevention Focus, Best Self. Lots going on. I love it. There was somebody shy. There was a lot of support from our elected officials at that event. There was some incredible music. You know, we all know that music for a lot of people is very healing and therapeutic. That's his boss that we just passed. Oh, that and Monica Wallace, I did not know that Assemblymember Monica Wallace had lost a family member, and she got up there and shared her story. It was, you know, as much as we're involved in this work, but anytime you hear somebody's brave enough or courageous enough to share their story, it's so very important. This was our singer. She was incredible. Oh, I don't, does anybody know her name? I don't recall her name. She again shared her personal story. Unbelievable. Stacy, she's a gem. That's Pastor Al, who's my neighbor. Oh, and then this was the other thing that struck me at the end. Anybody who wanted to come up and share something personal or share something about a family member, again, the bravery that it takes for a lot of these people to just stand up and share. It's again, without words. I think you might know this lady. It was really a beautiful opportunity to put faces to we talk so much about the clinical part of it, the numbers and all of that. It just was such a great opportunity to put a personal touch on what's going on. So coming up in terms of some events for the family, we are going to have the annual Christmas tree at County Hall. And we've also been asked, our committee has also been asked to partner with Colleen Brennan, who runs the Alden Substance Abuse Prevention Coalition. I think I got that right. And her youth ambassadors have asked us to partner with them on a Christmas tree that's going to be in Alden as a memorial to those who have been lost to the epidemic. So we're looking forward to that. So lots of things in the hopper, as they say. Did you want to add anything?
Yeah, the outreach team at Group Ministry, we're finding that community is a lot more receptive to Narcan if we place Narcan fentanyl strips, xylazine strips in barbershops, beauty salons, corner stores. Of course, there's always that slight language barrier with the corner stores, but we've kind of like navigated that because sometimes one of my outreach workers is female, and oftentimes, the corner store owners are not really receptive to speaking to females. But we decided that the best way to do that is to buy something first. And then it kind of like bridges a little, really it does. It kind of like changes the atmosphere. So now they're more receptive to what we are offering. But we've gotten a huge response from the corner stores, particularly in neighborhoods 14215, 14211. And this is where we focus most of our attention. I'd also like to say the last thing is that I got an email this Friday from Alicia, I think it was. Aisha. I got to say Aisha. Listen, I spent all morning trying to remember your name. She has informed me that they do have Narcan stations. I can run and kiss you for that right now. I'm really excited about that because we've gotten huge response through those Narcan stations, particularly in problem areas like Broadway, over in Central Park Plaza. Those are our highest demand areas. And I'm really grateful for that because we can put more out and get just more Narcan. Appreciate you guys and great seeing you all.
Thank you.
Thank you. All right, this is another, I mean, I think I've been here for a couple of meetings, but I've sectioned myself out into this specialty guest speaker area. And again, this is my call out. If you think your agency, your program, your community has something that you would like to present on, that you think warrants an agenda item, please feel free to reach out to us and we'll get you added to the agenda. Versus, you know, at the end of the meeting, we'll also have a community share out that if you don't want to be permanently on the agenda and you just want to share out, feel free to speak out at that community section. But I will talk a little bit about Erie County's opioid settlement activities. I don't have many updates specifically around Erie County. I've got some, but I have some things that I want to share specifically around the New York State Settlement Board and really what we're looking forward to come in 2025. We've seen this before, some background, fiscal status, programmatic activities, New York State comparison in a public view. I'm not gonna go over this because I've talked about this a couple of times and you can see it, but this is really where we got to where we are. And unfortunately, we've seen so many overdose deaths, but fortunately, we do now have additional resources that we are able to tackle in the community. Just a timeline, and hopefully we will add to it. So one thing that I talked about last time is the idea of what these anticipated payments actually look like. And so when we first started having the settlement conversation and we were starting to settle on Erie County specific settlement, is we had gotten these really large numbers. And at one point it was 64 million in the beginning, and now we're kind of trickling up towards 74 million is what we're anticipating on receiving over the next several years. But the problem is that we didn't just get all of that, or we aren't just going to receive all of those monies in one check at the same time. It's actually been structured through 2040, starting in 2022. And so I do think that that's important for the community to realize is that us at the county, we have gotten notified that we are receiving X amount of funds, but we want to wait until we allocate those funds, until we actually have those funds in hand. Because we don't want to commit to the community when we actually don't have those funds in the bank and then have to pull back and say, oops. But that also being said, we are routinely looking at how we are spending and investing these settlement monies and thinking, where are ways that we can pull back? Can we supplement with other funds? Can we look at new grants so that we can transition these expenses from settlement money off to the county budget, off to other grants? And so that is something that we are routinely looking at. This is how quickly, and this is another chart that I had showed last time, but this is how quickly these payments are changing. And so the orange line, I want to say it's the orange line. Yep, the orange line is what we originally were anticipating on receiving. And then within, I think, a day or so, we had gotten notice that we were receiving a different payment on a different schedule. And that really changed the first couple of years through roughly 2027. We want to stay where this green line is so that we aren't overspending in these beginning years, so that we have money and enough funds that we can continuously invest in the community throughout the next several years. There are some nuances, again, unknowns, renegotiations, slowed payments, notices versus checks. So yes, we're grateful that we're getting that 74 million that we can invest into the community. But until we actually have those funds in our bank, we don't want to commit. Restricted versus unrestricted at this point in time, both our budget director and our county executive are committed to treating every single penny as restricted funds. And so what that means is that no monies will be used for anything but opioid abatement strategies. Payments without description. So we've gotten a couple of payments specifically through Oasis where we've had to do a little investigating on where did that money come from? Was that an advance payment? Was that a payment that we haven't received yet? And then we've also had some nuances when we report our spending and our programs to Oasis. There's been a couple of new reporting mechanisms that have come out that we've got to investigate. What money do we report on? Because we do, as I mentioned, we have two kind of channels of settlement monies. One through Erie County specifically, and then one through the New York State Attorney General's office that comes and flows through Oasis. Some internal guardrails, I won't go through this because not much has changed, but it will be in the presentation. And as I mentioned, that we are routinely looking at spending and where we can really make sure that these funds are sustainable. General themes, really the same. We are meeting in a couple of weeks with Erie County leadership to look at really the next fiscal year. We've looked at the budget already, but we want to look at what our actual activities and actions look like. Some general themes of the New York State Settlement Board. And so I want to apologize if I get the purpose of this board incorrectly, but from attending several of these board meetings, it is my understanding that this board is really here coming together with many professionals in the overdose, opioid, substance use world, treatment world, to really provide communities, local governments, state governments with the best practices or the best way that we can spend and invest these monies. And so through that, we have received, or I have kind of captured some of these major themes. Again, these are my opinions or my takeaways, so they might not be totally on board with what the board had suggested, but my takeaways. And I have continuously noticed that timeline is not to be anticipated as we've seen through my chart earlier, receiving money at different time, or not on time, or different amounts. Co-occurring disorders, that's something that the board has really prioritized. Housing is something that the board I believe will continue to prioritize the sustainability of not only the funds, but the programs that the funds are funding. And so really making sure that we've got to have this balance of using these monies as seed money, so getting things off the ground, but then being able to help with that sustainability so that once the seed money is no longer seed money, or once the investment is no longer there, how can we, especially at the state, at the county, really help community programs, grassroots programs, and their programs be sustainable within these funds. And some of that might be through other interventions such as policy, education, and influence. Grassroots funding, so this is something that not only have we kind of talked about at the county level, but also at the board level, is how can we invest in grassroots? We've heard several times throughout today that us, whether we are the county, whether we are a hospital, whether we are a community agency, we're all really great, but we actually need to be in the community, and the community needs to be driving the conversation. And so how can we really lift up these grassroots interventions and organizations so that they can really be that platform that we need for everyone to be successful? And so we will kind of see what the New York State Board recommends and how Erie County can adapt it so that we can really be successful in our community. They are coming out, and they did vote on some recommendations for 2025. Those should come out soon. And then one new strategy, or something that has been talked about a couple of times, but really pushed this last time in something, or this last meeting, and that I took away, is that talking with New York State Governor on declaring a public health state of emergency of the opioid crisis. And so I am not a policy expert at all, but something that came up several times is that if the governor was to declare this emergency, that really lifts some challenges and barriers for treatment providers and healthcare providers and community agencies to serve better. What those challenges and barriers are, I'm going to be completely honest, not my world. But I would love, and I'm extending an arm to see if anybody does have an interest in this and they want to lead an unofficial subgroup at this time, so that we can really make an informed decision and be able to have these conversations to say, actually, this would be really, really impactful in Erie County and statewide. And here are all of the reasons why. And here are all of the things that we could do and can do better if that declaration was made. And so, again, my hand is reaching out to somebody who is more versed or has really good ability to kind of navigate that conversation and what that looks like for the community. Some challenges that I've identified from my position as directing the opioid settlement monies through Erie County, and how I and the New York State Board interacts, not that we interact personally, but attending the meetings, is that there are several recommendations that are really appropriate for state governmental agencies, such as OASIS or Department of Health for New York State, mental health for New York State, but they might not be totally appropriate for local government, or there's some reason why we couldn't use that recommendation. And so once those recommendations come out, it will be really interesting for us at Erie County to look and say, you know what, that really is for a state institution, but here's how we could adapt that locally and what that looks like locally for us. Timeline of recommendations. It's kind of like we are 3 cars that are racing on a 3-way highway. So Erie County is doing the work, and New York State is doing work, and the board is doing the work. But we've already come out with our budget for 2025. The board has not yet approved or solidified the recommendations for 2025. And so we're kind of at this push and pull of how do we pre-plan and kind of consider these recommendations, but when are these recommendations actually going to be adapted, and how do we work towards those recommendations and actually using them and implementing them into our community. And so that'll be interesting as we move forward. There are regional differences. I think everybody knows that. And then as well as there's a reporting format that we report to OASIS, and to date we've reported all of our money spent. I don't know if that's because we received Erie County settlement and settlement through OASIS. I don't know if that's really appropriate, so we'll look at that. But also, if OASIS is going to change the reporting format to match the New York State board recommendations, that might not be really appropriate for us to report in. Because like I said, we're on that 3-lane highway of everybody kind of driving at different speeds and different times, and I don't know how that will work. So we will see and communicate as we move forward. Couple of campaign updates. So the first slide of today's meeting had one of our posters from the campaign that we've invested with the settlement monies. We won gold winner for best advertising campaign in the Muse Awards. So it's a fun factoid. Some analytics. So the lift, what this means is that we are at 33%. The industry average is typically around 13%. And my impact, if you are on virtually and I say this wrong, please drop it in the chat. But my understanding of the lift is that within 10 minutes of the ad appearing, specifically the radio ad, within 10 minutes, how many folks take that information from the radio ad and get to our website? And about 33% is what they are suggesting, which industry average is 13. So that's pretty excellent. They are overly ecstatic about that, which is great. We've had to date 12.5 million impressions. So that could be seeing it, hearing it, clicking on it, and getting to our website. So that is really awesome to see as well. And then 109,000 visits specifically to that particular web page. And I hope to share more information on if the behavior change of actually requesting supplies, what that looks like in the future. We are going to tweak our messaging just a little bit through the holidays. We have seen over the couple of years that around the holiday season, we do see an increase of overdoses and overdose deaths. So we're going to tweak the message just a little bit, no images, no style of the campaign, but really just put a message out there that it's the holidays, you might be in from out of town, you might be bringing substances in from out of town, and that those drugs may be different, and here's steps that you can do to help protect yourself and your community. We are talking about year 2 planning, and we recently refreshed some images to avoid viewer fatigue. And here's a couple of images that I also showed last time as well. And Kim Tran, a family member who has been with us for a couple of years. What's to come? I am receiving some program reports, so I do hope by next meeting I have some idea of what those programs look like. We are still working on a website, including the dashboard, so what our finances look like, what the programming looks like, reporting, as well as we want to receive community feedback, comparison, and then a multi-year report will be coming out in 2025. Another quick look at what I hope the dashboard will look prettier, but it'll contain some of these information. And then here are some inspirations that I've pulled from. across the country. And then any questions or comments, here's my contact information, but we will have some question and comment sections at the end. So community share out. This is really a portion that I hope to keep once the new director does come on board and we find somebody. But I think it's really important that this is a space where we are all together. And so even if you cannot commit or you aren't on a work group, you still have the space to share what's going on in your world. So if opening it up to the floor, if anybody wants or has anything to share out, please feel free to just, yeah. And Melissa, if there's anything virtually, I don't know if you can unmute or how we would hear, but if they can just drop it in the chat, that would probably be the easiest. Okay. Yeah, Yvette.
Hi, my name is Yvette. I'm the founder and executive director of the Connection to Giving Back. So we are now approved by the state to have the second tier a needle exchange in Buffalo. It's in the process. I will bring more information as soon as the state gives me more information. Plus, we have an event in the community of Miller and Broadway, the 16th, I think it is. On Broadway, if anybody are welcome to come and be part of the community because the community needs us.
If you have anything to share, if you can email that to me and I can email it out when I send out all of these resources. Yeah.
Congratulations.
Thank you.
Anyone else before we jump through? Yeah, Jordan. Yeah.
So just from the Erie County Department of Health Office of Harm Reduction outreach, that's mainly what I do there. We have restarted outreach. I know there was a pause and everyone found out about it through various communication methods, but we're back out. All of our peer navigators are back out on the street, and we're working on also expanding to other parts of Buffalo as well as other parts of Erie County. We're working with the city of Buffalo to get some parking permits in other high overdose incidence areas, as well as potentially doing some outreach in Springville down the road. So yeah, just wanted to bring that update.
Thank you. About the medical?
The detailing?
Medical.
Oh yes, and then we also are working on bringing medical students out to our outreach, just so we can educate people about what harm reduction means, right? I think when we get people young and in the medical school and teach them not just about what the practices are, right, but what the philosophy is and what that means for how we treat people from the moment we see them to the moment they walk away from us is really important. So it's been great to have medical students out on outreach because the peers can really influence and show them what that means.
Thanks, Jordan. Yes.
I'm Nancy Nielsen. I'm Senior Associate Dean at the Medical School. And just to build on that comment, we're very proud that we're sending our medical students out to community-based organizations for a variety of experiences. This is one of them. But I thought you all might like to know that when our brand new class, which is now 180 medical students plus 4 PhD, MD, PhD, so 184 kids showed up. Within the first 2 weeks of the curriculum, what we had done is we showed Dr. Burstein's slides. And one of the things you might want to know is, remember that they talked about the non-fatal opioid overdoses? You know where the medical school is, right? Main and High, Main and Allen. Allentown is a hotspot for the non-fatal overdoses. So we did Narcan training with all 184 kids and made sure that they had access to it and carried it. One other thing you might like to know, this is a little tangential, but I think would be of interest to you, is we have hired a new director of interprofessional education, which means that person helps bring medicine, nursing, pharmacy, social work, dentistry, who am I forgetting? Somebody else? Anyway, you get the drift. all of those schools at UB, and he's a really interesting guy. He was not the kind of person we thought was going to apply. He was a drug rep for 10 years, became disenchanted with the kind of detailing that, yes, influences behavior in a bad way, right? Left that, earned a PhD in medical anthropology, and is very, very anxious to help us make sure that the pressures, the economic pressures that we all know about, are understood by the students in all of those fields. And they're going to bring, he came from the Medical College of Wisconsin, and they have an interesting program that's called Pain Stewardship that they're going to share with us probably in a few months. And that brings me to the last thing I wanted to mention. As some of you may know, New York State has a pain management task force now that is looking at a variety of things. The opioid guidelines from CDC, which had some good effects and some unintended consequences. How do we handle that? Also, there's a subgroup on non-opioid pharmacologic management, so drugs that are not opioids used for pain. And I bring this up because it was really clear several years ago when we met with the leaders of all the big addiction provider agencies, that the people they had the most trouble dealing with were people who had legitimate chronic pain and had to be on opioids. And what do you do? How do you help them? How do you monitor them? So stay tuned. There is another part of that task force that is on non-pharmacologic, so non-drug management. Things that have come up are no surprises. Cognitive behavioral therapy, acupuncture, all kinds of things, most of which is not reimbursed, particularly by Medicaid. And so those are the things that are being discussed. That task force will make preliminary recommendations, I'm told, by the end of the year, that the governor may want to include in her state of the state, but they will only be preliminary. So stay tuned as we in the educational field are trying to help you get to a better world.
Thank you. Thank you for sharing. And if you have anything to send out, if you have any literature or papers, I can send that out to the larger group. Yes.
Thanks, Taylor.
Yeah.
Hi, everybody. I'm Matt Smith. I'm the Executive Director of Prevention Focus and also the Chair of the Western District Defense Consortium and TF21. A couple of things everyone should be aware of kind of going on right now. We spearhead the local SOAR grant umbrella awareness campaign called Take It to the Box. You may have seen the yellow and black billboards. They're all over the 8 counties of Western New York periodically during the course of the year. We also invest heavily in print ads in the B's and small print publications that impact all 8 counties of Western New York for the Take That Day that just occurred back on October 26th. Remember, we're trying to get people to routinely clean out their medicine cabinets and do that in a safe way, whether that's using a deactivator bag like Era or take it to these different boxes. Many pharmacies have them now, and try to get people to do that to get the unwanted prescription safely disposed of. So there's an ongoing campaign that's doing that, and we urge people to get involved. When you go to the pharmacy, you might have seen a yellow sticker maybe placed on your bag with take it to the box, or a little card put in there, or actual bags that they use. We are distributing those as well across the 8 counties, so be on the lookout for all that stuff. Also, just from an awareness perspective, because none of this stuff exists in a vacuum, it is Impaired Driving Prevention Month very soon. So from the night before Thanksgiving all the way through the new year, we are encouraging making sure that people refrain from impaired driving. And that's being done in a couple of ways. One is a billboard campaign, another is at the Erie County Fairgrounds Festival of Lights. If you've ever been to that, the drive-through thing, you see all the light displays. There'll be a mini billboard in there, as well as the Drive Safe Tree. The Drive Safe Tree is a simple little thing. We find in prevention, you get something that people to do things they're already going to do anyway, that it's a nice, effective thing. It's a template available through Western New York United Against Drug and Alcohol Abuse, EV download, of an ornament that kids can color. And each ornament represents a child's wish that the adults in their lives refrain from impaired driving over the course of the holidays. And there'll be a whole forest of those drive safe trees at that Festival of Lights if you get out of your car and go to the buildings in there. But any municipality wants to make an existing holiday tree a drive safe tree, it's real easy. Put those ornaments on there with little signs, you know? We encourage schools to do the same thing. So all these things are kind of happening and being involved. I wanted to make sure that, you know, in context of all the other awareness stuff that's happening too.
Yeah, thanks, Matt. It all intersects. Absolutely. Thank you. We still do have the question and answer. So if you have any questions, please feel free. This is the time. I like take it back, ask questions first, and then I'll go to the next slide, which is our feedback slide. Yeah, Abby.
I have a question about Best South and the expanding to the 24-hour, the whole new thing that's going on.
The Crisis Intervention Center.
There you go.
Yeah.
I know where you are.
Yeah.
Okay, you said they stay in 24-hour.
So, yeah, it's not a place where people can stay overnight. So
What happens after that?
they're all linked to whatever other things
So
that
you
they
link
need.
them
Yes.
together.
Yes. So again, so that's the idea of it's of somebody who is in a crisis that doesn't need that emergency level of, intervention,
Right.
but yet needs some kind of immediate connection. So if it, it could be, if it's psychiatric, then the psychiatrist or psych NPs will be meeting with that person, assessing, giving medication if appropriate, and then so if it's, if it's a substance use crisis, then that'll be addressed co-occurring probably most likely, and all of those things will be, so we'll have providers on hand that can address all of those things, nurses on staff, they'll be peers, social workers.
I didn't know if it just ended there and
No.
they had to go or
Yeah, and if you talk to the folks who are in charge of it, it's like if we're in the process of linking somebody and it rolls over a little bit, we're not going to be like, you have to leave.
Okay.
We're gonna see that person through until that linkage actually happens. But technically, it's just to be clear that it's not an overnight facility, so people aren't going to be hospitalized, if that makes sense.
Yeah.
Yeah.
Thank you.
Mhm.
Thanks, Abby and Jen. Dr. Burstein.
Thanks. Oh, I have, sorry, another question.
Yeah.
I was just interested, I mean, you can tell from the data we presented that, kind of stimulant use disorder is emerged as a big problem.
Yeah.
And I saw that you had some type of work group or task force that was trying to figure out how do we address that in the community.
Yep.
Do you have any recommendations yet or suggestions? I mean,
Yeah.
it just seems like, I don't know, there's really no good answers, at least what am I reading?
Well, so I think it's multifaceted, right? So first of all, there's the folks that are just seeking that I'm hit this space where I'm just like, I need to do something, right? So we know people hit those kinds of, and those moments can be very fleeting. So I see that the crisis center can be a place that somebody could just walk in or call, or, and just have somebody to speak to about that. And then maybe get that linkage to a more longer term substance use program, whether it's an inpatient program, residential, outpatient, whatever seems to make the most sense for that person and what they're seeking. I think when we look at actual substance use disorder treatment and treatment for stimulant use disorder, I think we're lacking. And so one of the things that we're talking about in the work group specifically is around contingency management, which is an evidence-based practice, but it's not very popular, and it's also not allowed by Medicaid. So there's really not a way to do it and then bill for it. So we're trying to figure out as a group, where's our next steps? Are we looking at advocacy? First of all, we have to pull in all the data, right? So there are pilot programs that have happened in the country that show really great outcomes around contingency management. So can we pull in their data so we can advocate, in that space? Is there a way we can kind of start it without doing the full evidence-based practice, but there's some things within there that we could be doing? We're also talking about medication that's available. So there's some, information out there that's off-label medications being used for treatment of stimulant use disorder. There's no actual, medication for stimulant use disorder specifically like we have for OUD. But, there are also, so as a work group where we're trying to pull in like what exists, what are some emerging practices, what are some evidence-based practices that are there, and how can we kind of bring that to the community, the treatment community at large. So it's a pretty big task, I will say. But that's something that we really, that's kind of been the focus of what we've been talking about.
Thank you.
Mhm.
Thanks, Jen. Melissa, do we have, oh, yeah.
Sorry, we're sort of new to this. We've sat on a few virtual, but we're for Big Brothers Big Sisters, and we actually have federal funds to provide mentoring to children who are in families that have been affected by substance abuse. Right now, we have available spots for girls that they could get matched pretty quick. So if you're working with someone that you think would benefit from having that. But that being said, we're always also looking for unique ways to engage our families in preventative information and opportunities to help them obviously prevent sort of end the cycle. And what's very interesting, and what I saw talking, when you're looking at the zip codes that are seeing spikes, those are where most of our kids are living. So reach out, I guess. And we would love to accept some of the kids that you think could benefit from mentorship.
Do you have my email address?
I think so, yeah.
Okay, could you send me a couple of things and I can send that, your contact information out to the group? Oh, wonderful. Parker.
Yes, I have a question. So I don't think that this was touched upon, but you guys kind of talked a little bit about people who kind of want that treatment right then and there, which is what I believe the like crisis services is going to be, you know, dealing or whatever. So is there, or how does all of this kind of relate to people who kind of like need detox or they're interested in detox and they go to the detox program and kind of like what you said, they're turned away because they don't meet those qualifying thresholds, or I find a lot of times we are able to get them into detox, but there's also a long period where they're just waiting there, especially like at ECMC, like they'll be in the waiting room for like 20 plus hours, which I think is one of the biggest barriers that we're seeing from individuals who are seeking out detox. So is there any ways that all of this stuff is going to be working with that or anything, or do you know what I'm talking about?
I don't know if anybody has, feel free, if anybody has an answer, suggestion, feel free to jump in.
Yeah. Well, yeah. I was going to say also, I mean, there's gaps, right? There's gaps in the community in different spaces. And that's, so again, Intensive Crisis Stabilization Center, I think, does fill some of those gaps that once that's open, I think it will. Is there any one perfect solution for everything? Absolutely not, right? So, but I think that will be a big assistance in some of those gap spaces. You know, we also at Best Self have a low threshold buprenorphine program. So that is a walk-in and access to medication. That's at our Lower West Side location, which is 951 Niagara Street. So that's just when the clinic is open. So obviously that's not a 24/7 operation, but any of the regular clinic time, there's a walk-in to get rapid access. And when we say low threshold, that also means, which a lot of people, when you go to a traditional behavioral health care organization, you're going in for medication, you're also having a counselor and peer services and all those. Low threshold means you just do what you want. Like in a sense of, if all you want is medication, that's all you get. That's all you have to do. You see the medical provider, get your medication and go. We have peers available. So if you want to speak to a peer, you can. If you decide you want to see a counselor, they're there and we can link you. But it's very much like, it is very person-centered. It's you as the individual, what you're looking for, that's what you get. So that's another option for people who may be using opioids and seeking support, you know, in that way. But yeah, I mean, I think, again, like, you know, there's no one thing that can meet all the needs of all the people all the time, right? So ECMC can't meet everything that everybody needs, and Best Self can't, you know, I think it is like, I think the beauty of a group like this is where we get to identify those gaps, and then are there other strategies that we could be looking at to do? So I think there's more coming, and I think we have to keep doing the work.
You don't have the detox right now.
We don't have detox.
Yeah, that would be great, because I work at the detox at ECMC, I do groups there, and also a big barrier that I would also love to see regarding detox as well is that, and also just long-term treatment, is that a lot of people are unable to go into long-term treatment because of financial responsibilities. If they have a mortgage, they have a house, they have a child that they care for, those are oftentimes barriers that lead people to not be able to get into recovery even if they want to.
Parker, I hope you're going to join the living and lived experiences of the harm reduction subgroup, because these are all really phenomenal conversations that specifically, not only can come back to the larger work group, but these are like those real-time conversations that can be brought up that you're hearing from out in the field back to the system and be able to, again, like Jen mentioned, identify those gaps, have the conversations, and possibly identify some solutions.
Same thing with Monday though.
Yeah. Melissa, any questions on virtual?
Not a question, just Jeremy from Horizon said Horizon Village Terrace House at 291 Elm Street provides medically supervised detox and stabilization services, and they also provide walk-ins from 8 a.m. to 8 p.m. daily. They do not need to be in withdrawal or need detox to be admitted.
Okay, awesome. We will get the whole chat activity, and I'll put that in as a solution answer to some of the questions. The last item that I really want to make is that in the federal government that just came out with some legislation around accessibility for governmental institutions, and so we have to follow that to make sure that all of our communications and all of our activities are really accessible to the larger community. Part of that is specifically looking at our visuals, and so I'm going to be volunteering. Melissa is going to help on this, but we are going to come up with a really quick guide on how our work groups and our community members can make sure that they are following some of the accessibility guidelines that we have to follow. That's really because we post these on our website and it has to follow the accessibility. But we don't want you to do more work, and so we also will come up with a template so that you can easily plug and play your information in case you don't want to take up, some of those tips. So that will come prior to our next meeting. And the last thing is that we would love to get your feedback from this meeting. This is feedback on the meeting, not feedback on the task force. Feedback on the task force will come at a future date, but let's start here. There are 4-ish, I wanted this to be short and then I got carried away. So there are 4-ish questions, 5-ish questions that are mandatory, or I really hope you do them. And then there's a series of several questions that are optional. You do not have to do all the optional. They're the really boggy ones down at the end, but it is really great information and feedback for us to have. So that is it, virtual participants. Hopefully you also can access this. We appreciate you coming in person. Dr. Burstein, do you have any last comments before we part?
Yeah, just again, want to thank everybody for coming in person and virtually. I mean, I think it's really important that we come together quarterly and connect and share what we're doing. And I mean, I think this was a great exchange at the end. I really like seeing this, that we interact with each other, ask questions, learn from each other. So, hopefully we, let's continue this. So thank you. And thank you for Taylor for stepping up.
Yeah, absolutely. Here.